All right. Hi, everyone. Welcome. Thanks for chiming into the chat. It's so nice to hear from everyone. I know it feels like we're all kind of just speaking into an empty void these days, but it's nice to see you all there, and we appreciate your comments. So please keep the chat lively, keep them coming. We love to hear from you guys. Thank you so much. So yes, welcome back to Mini Med Session 4. I can't believe it. We have made it to the month mark, which is incredible. It's been fun every week. I know I've learned something every week, so it's fun and exciting. Hope you all feel the same way. But thank you so much for coming back to join us for Session 4 at UCSF Fresno Mini Med School. Let's see, I'm going to go ahead and put the YouTube link into the chat right now in case anybody wants to catch up on any of the previous sessions that they may have missed. So let me go ahead and put that there. And then in the housekeeping slides, I had a slide about the Liver Expo that's coming up. So Dr. Marina Reutman, who is going to be speaking next week, she is hosting an event, which is public. It's going to be on Saturday, and it's going to be the 2020 Liver Expo. So we're going to have liver health lectures on fatty liver disease, on pediatric fatty liver. We're going to have some nutritional slides. We're going to have a cooking demo that should be really fun. So please, doesn't matter where you're located, go ahead and join us if you like. It's going to be on Saturday, October 10th from 9 a.m. to 12:30 p.m. and that's on the West Coast, so PDT. Forgot to tell you, I know there are people attending from all over the place, so please share that information with any loved ones that may be interested in coming to that, and you're also welcome to join. So it should be a fun event. Yeah, so wanted to go ahead and pass it over to Dr. Dillon, who you know and love by this point. So I won't bore you with all, not bore, let's not say bore, it's not boring, but let's not go over, rehash the details of Dr. Dillon's past. We all know about it now, but I did want to tell you about, the UCF, Community Regional Medical Center Emergency Department. So that's where Dr. Dillon works currently in emergency medicine. And I wanted to just give you a number that I thought was kind of impressive. So let's see. The UCSF Fresno or CRMC emergency medicine faculty, like Dr. Dillon, are responsible for 114,632 patient encounters in the emergency department over the past year. So she's busy. She's a busy gal. And we appreciate her taking the time to be here with us. So I just wanted to let you know what they're dealing with as faculty, and it really makes it even more impactful that she takes the time to be here. So thank you, Dr. Dillon, and it's all yours.
Thank you, Summer. You're too nice. But yes, our ED is actually one of the biggest EDs in the state of California. It's at least in the top 3. We sort of fight, I guess, with some EDs in LA to win that spot, #1 spot. So we go back and forth, but it's a pretty big ED if you've ever been. And we have some great staff here. So what I'm going to do is I'm going to share my screen and let's do a fun question. And then I will introduce Dr. Kraus and we'll get started. So I'm going to make this full screen. This is an interesting one. If you could be famous, what would you be famous for? Can't wait to hear what you guys have to say. I know it's a hard one, but I'm sure you guys have got good answers. I like it. I love photography myself too. Writing, love it, Nobel Prize, perfect. Singing, nice. Vaccination, vegan, okay. Creating, acting, love it. You guys are so many creative people out there. I love it. Comedian, anime, change, okay. I love it. Acting and comedian is pretty much winning it. I wish I could act or could be funny. That would have been pretty good. Or dance.
I think you're funny. Okay, Suki?
Thank you. Appreciate it. Appreciate it.
We'll take this show on the road.
Yes, exactly. Look at that. You guys are amazing. I wish I could meet pretty much all of you guys. At least see your faces. It's unfortunate that I can't. But hopefully in the future, for sure. Thank you guys for sharing. Without taking too much time, I'm going to stop sharing. That's pretty cool. We will move forward. So I'm going to stop sharing here, and I'm going to introduce Dr. Kraus, our first speaker today. So Dr. Kraus is actually a board-certified child and adolescent psychiatrist who received her medical degree from University of Washington and then completed her residency and her fellowship in child and adolescent psych at University of Colorado Health Science Center. So that's pretty awesome. In addition to teaching physicians in training, so the residents that work with her, and medical students, she also serves as the medical director of child and adolescent psych at Community Regional Medical Center, which is pretty amazing because it's such a special niche, a fellowship that you, in addition to getting your psych fellowship, you have a psych residency, you do additional fellowship to get trained in this specific area. So that's pretty amazing. And she's the director at CRMC for it. She's earned several awards for her advocacy on behalf of youth struggling with mental illness. And I'm pretty sure the pediatric department and the psych department and the ED, of course, everybody is very thankful to have Dr. Kraus on our team for sure. And I'm gonna let her share her interesting fact with you guys when she gets started, and we'll go from there. Dr. Kraus, take over the stage and we'll go from there.
Hi, I'm glad to be here. I was asked to start out by talking about the thing I'd like to be most famous for. And before I was a physician, I was a biologist. And what I would like to be famous for is to be a famous botanist and known for my expertise in California native plants. Lot less interesting than everyone else, but there it is.
No, that sounds pretty amazing. Now that we're redoing our yard, that's what I've been looking at, native California native plants. Yes.
Absolutely. Absolutely. Now I just moved this. Here we go. In any case, I guess I'll start. I promised Dr. Mcmillan I would not run too much over into his time. But I wanted to thank everyone for coming and explain that the topic for this talk was inspired by publication of several recent articles documenting the increased incidence of psychiatric symptoms and disorders in children across the globe since the onset of the coronavirus pandemic. And these reports are from countries affected earlier in the course of the pandemic, specifically China and Italy, but they mirror what practitioners in our community are seeing. A very concerning rise in youth, particularly teens and young adults presenting in crisis, including a very marked increase over the past 6 to 8 weeks, sort of nominally associated with the start of the school year, of kids admitted to our emergency rooms in hospitals following very serious suicide attempts and overdoses on drugs. So during my talk today, I wanted to share some thoughts about why this group, kids ages 11 to 12 to 22, may be so vulnerable to these profound disruptions in daily life caused by the pandemic. And in my 30 minutes, I am going to try and explore the unique stressors impacting this age group, as well as some of the biological and developmental factors that sort of underpin this vulnerability. And hopefully, if not during the talk, certainly during the Q&A, discuss some strategies for people in the audience. I understand this is a sizable population of people from Gen Z, and maybe you'll find something helpful in that aspect of the talk. Adolescence is a crucible of development, a situation where different elements and sort of concentrated forces interact and come together in the process of creating something entirely new. And in that vein, I thought I'd begin the talk by just reviewing some of the sentinel features of this developmental period. So as I suspect everybody knows, that adolescence is divided chronologically into 3 different phases. An early phase, sort of encompassing children 11 to 13, a middle phase, including children 14 to 17, and then late adolescence and emerging adulthood, ages 18 to 22. Each of these phases has unique characteristics, but for purposes of this talk, I'm going to sort of paint a broader picture. From a biological perspective, though, adolescence development is activated by the onset of puberty, which begins between the ages of 8 and 14 for girls, 9 to 15 for boys. And as everyone knows, it's associated with an increase in the production of steroid hormones, i.e. sex hormones, and the development of secondary sex characteristics and ultimately reproductive competence. So the point that I want to bring up at this point is that though in addition to these really dramatic physical and physiological changes, sex hormones like estrogen and testosterone also target diverse areas of the brain that affect many aspects of maturation, ranging from gene expression and cellular functioning to the formation of these complex neural networks that give rise to this growing repertoire of behaviors. From early childhood on, kids spend an increasing amount of time with peers. But in the adolescence, their peers and their friends become the most salient aspect of their existence, the central defining feature of their daily life. And with that comes a whole set of new social roles. Teammate, employee, girlfriend, boyfriend, babysitter, caretaker. And with that is this increasingly sophisticated array of social skills. Part of this movement into the broader world, this exploration of the broader world, is accompanied by an intense interest in novel experiences and experiencing new things. And even though teens and young adults remain in many ways dependent upon their families for support, for supervision, adolescence is a period of emerging independence and what we refer to as agency. And it refers to the ability to initiate and direct actions for given purposes. It's the idea that a person can act on and control their environment. It's sort of the equivalent of what we think of as an internal locus of control. And it's related to the concept of self-efficacy as well, which is this idea that you have the abilities and the confidence to do these things. Adolescence is associated with this process of coming to understand who you are. And when we talk about this sort of coherent self-identity, that's everything from what you want to be when you grow up to your gender and sexual identity, and all these things become consolidated through this period. In this process of emerging, this central focus and immersing in oneself in the social world, relationships become more complex, and ultimately, adolescence involves the formation of intimate relationships and the emergence of romantic attachments. And then fundamentally, adolescence is a period where kids develop the life skills they need to be successful adults. And they look at this on national surveys, and what kids identify now, what kids I'll just generally refer to adolescents and Gen Z folks in this conversation, they've identified education and economic security as the critical skills that they require in order to be successful as an adult. So why are young people stressed? If you look at this list, these aren't things that are particularly, one would associate as particularly restricted to young people. But we'll talk more as we go along about how, or maybe even just looking at this list based on how I've described these sentinel features of adolescent development, you could see why this might mean more to somebody in that age group. Obviously, the threat of illness is shared by everyone, but I think it becomes, in general, interestingly enough, pandemics are associated with a greater degree of stress than other forms of natural disaster. And I guess it has to do with the uncertain, unseen, indeterminate quality. What are you fighting? What are you trying to fix in this context? And I think for kids, it's very perplexing because there's been a lot of confusing information about what this means for them, given conflicting information about the risk posed to young people in the context of the pandemic. Obviously, there's the loss of normalcy and familiar routines, most notably the dump into online education that occurred last spring, and the only slightly improved version that students are now engaged in this fall. With that, the very close association with social isolation, both because they're no longer in school, but also because of just the lockdown procedures, the social isolation procedures that have had to go into place. Something that dramatically affects people in this age group is getting back to this idea of roles, that they are either constrained in roles that they have outgrown, i.e. moving back with your parents, or being thrust into roles that they're not developmentally ready for, becoming a provider, becoming a caretaker for younger siblings. There's a loss of meaningful life events. And if people think back to their experiences, there are a series of events that kids go through in this age. It's their final sports season, their prom, their graduation, all of these things, leaving home to go to college. All of these things have been deranged in this process. Accompanying that is enormous existential anxiety about the future. People just can't really tell you what's going to happen. And kids are very worried about what that means for, in what is perceived as a very competitive world, what that holds for them. Like everybody, there's a loss of previously effective, healthy means of coping. With the air quality right now, everybody's encouraged to exercise. People can't even exercise. So what resources do kids have then to make themselves feel better? One of the things I mentioned earlier is that fundamentally, from a psychiatric perspective, we view this as a disaster. And we assess the stresses that arise in that particular context of trauma. And we know that in that context, that anybody who has any vulnerability to psychiatric illness or has an existing psychiatric illness is going to be far more likely to experience an exacerbation. In part, it may be because you can't even access effective services. And then there's grief and loss, which I think maybe Dr. Mcmillan is going to elaborate on. But for kids, I think that there's being epidemics within the pandemic that uniquely impact this particular generation, which is the most culturally, racially, ethnically, and religiously diverse population in the history of the United States. They cannot help but be affected by the events occurring in our society with respect to systemic racism. they can't help but be aware of the intersectionality between the pandemic and systemic racism in terms of health disparities, in terms of the differential economic impact of the pandemic. Related to that is this issue of climate change. I think for older people, we can be horrified by the threat of climate change, but I don't know that we anticipate living through it. And both of these things, this issue of climate change and these concurrent disasters like the wildfires, and then this, again, the sort of the political chaos that's engulfing our country, kids are left to think, can I even have plans? If I make plans, do they have any meaning? Is there any likelihood that anything that I do, right? This idea that somehow or another, if you work hard enough and you have goals, you'll be able to meet them. Is that even accurate given the events that are coming around me? The other thing we know, and we've known this for a while, is that this is a very impacted population of kids. Individuals, if looking at, there's a scale called the Perceived Stress Scale, which will accompany the posting of my talk online. What time did I start? Am I already done?
No, you're good. You're
okay,
good.
I'm going to talk fast. I'll talk very fast, Dr. Mcmillan. Anyway, there's the population of kids from 18 to 25, when they look at standard sort of use of standardized assessments to assess perceived stress, have the highest rates of perceived stress of any age group. We also know that there has been an increase in rates of anxiety and depression in this population, even preceding the pandemic. With, again, almost not about a 30% increase over the past 10 to 15 years. And finally, the Great Sleep Recession, which is the title of an article from Pediatrics discussing what is an epidemic of pathological sleep patterns in adolescents. And so we know that the sleep quality and sleep duration decreases from childhood through early adulthood. But what also is clear is that even over time, in a cohort effect, that sleep is deteriorated, which has been attributed to the demands of school and academic performance, the intrusions of social media, such that about 87% of adolescents in the age group that I'm referring to do not receive the adequate recommended amount of sleep. So 87% of kids in this age group receive less than 7 hours of sleep a night. Less than 5 hours is considered sleep debt. And this is on top of the sleep phase delay, which people have probably heard about, where kids need, their biological clocks have them going to bed later and getting up later. And they have schedules, in fact, that further disrupt their sleep by interrupting that. I'm going to make a couple of quick points about neurodevelopment. I really had to cut, this is my favorite thing. I'm going to try and really cut it down here. But I just want to make the point about the dramatic changes. You know, we talked about these dramatic changes in observed behaviors and experience, but these underlying this are very dramatic changes in the brain. So the process of change in the brain is very uneven. It starts in the back of the brain, it moves to the front, starts at the bottom and moves to the top. And in that context, what you see is that what we think of as being the primitive or evolutionarily conserved functions, emotions, sex, reward, develop more rapidly than these higher order cognitive and integrated functions, the ones that the ones that allow you to plan, to execute goal-directed behavior, to offer cognitive control and regulate your emotions. Another important feature is plasticity. So the changes that are occurring in the brain at this time parallel the very, very dramatic changes that occur in the brain when a child, for infants between the ages of 0 and 4. And it occurs through this process called experience expectant synaptogenesis. And what that means is that it is through the experiences that the brain begins to refine its circuitry. There's a process of pruning and organization that occurs to increase the efficiency and speed. So it's explicitly environmental learning that then shapes the brain. But you can also see then how that may make a child of this age group much more susceptible to stress. And lastly, and this gets to why social isolation is not the same for me as it is, you know, the botanist who would just be happy out looking at plants, and teenagers. The part of the brain that just explodes in maturation is the parts of the brain that relate to social, emotional, and processing, and very specifically in relation to peer relationships. We talked about how the brain becomes wired based on these experiences. The crucible of those experiences are peer relationships. During this time, kids have a very heightened sense of their own internal experience, self-perception. They have this they have this emerging capability of interpreting and being aware of and interpreting complex facial expressions, and with all their nuances in meaning and intent. They are very aware of and very responsive to social information, how other people are perceiving me, how other people are perceiving other people, and what people's internal states are. What allows us to look at somebody's face and say, "Are you okay?" And those responses are characterized. Their responses to these kinds of experiences is characterized by intense emotionality. For the same reason, this exquisite awareness of their environment, they become very hypersensitive to the value of novel or socially rewarding experiences. And the last thing that I think is important to point out is that in the context of this exquisite attention to people of their own age, there's a reliance on peer feedback for approval and a sense of identity, self-evaluation. So the saying is, the way that teens see themselves, particularly younger teens, is I am what I think you think of me. So you can see these issues of plasticity, these issues in capacity for self-regulation of intense emotional states and more primitive impulses, and then the importance of their peer relationships, both in terms of brain development, but also in terms of self-development, how these kids can be so impacted. I think it's important too to talk a little bit about the stress response, because fundamentally what we're saying is that there's a differential response to stress in these populations of kids. It's important to point out that there's that there's good and bad stress. And the definition of good stress is stress that can be overcome. You know, with stress, we have an activation of what we think of as survival circuits, right? We become more focused, our energy increases, maybe our heart beats faster. But when we're able to master something and recover back to our baseline, we actually gain agency. We gain a sense of efficacy, which allows us to confront additional stress in a much more kind of confident and effective way. It's when that stress overwhelms us, when that stress is repeated and does not allow us to get back to that state of sort of calm alertness, that we begin to see these negative effects. And when we think of that overwhelming stress or that repeating stress, we refer to that as toxic stress. And that kind of stress gives rise to what we think of as survival behavior. You know, I was sort of talking about these higher and lower functions of the brain. Survival circuits are pretty basic. That's like you see a bear in the woods and you run. And that gives rise to what we think of as the fight, flight, or freeze. First you argue and confront, then you avoid, and then you give up. So this is another way of sort of pointing out these two different patterns of stress and their different outcomes. So when stress is unpredictable, extreme, or prolonged, you get a sensitization. And what that means is with each different exposure, your threshold of response decreases and the intensity of your response increases. That creates vulnerability. That impairs a person to recover, a person's ability to recover. If stress is predictable, moderate, or controllable, a person is able to cope. And like I said earlier, that cultivates what we think of as being resilience. And resilience is defined as this ability to physiologically and psychologically adapt to environmental changes in a way that maintains your integrity emotionally and physically, socially. So what happens if the stress is extreme or persistent? So this is a famous depiction of the relationship between stress, and here it was originally developed as a way of talking about performance in sports, on exams, that sort of thing. But you could substitute functioning for performance there, and I think it might be a little clearer. So if you have no stress, you're not awake and you're not able to do much, right? As your stress increases, your motivation, your activation to engage in your environment increases. Think about healthy stress. Think about what it would be like going into exam if you were yawning. How would you do versus going into an exam like going, I'm ready. I've had my caffeine. I'm good to go. So there's a point in which motivation increases, focus increases, and performance increases. Ability to function improves. But it kind of crests out. And as stress continues to increase, you get a persistent stress response. Sympathetic nervous system is aroused, cortisol becomes dysregulated, and then you begin to see all these what we think of as these negative outcomes of stress. And what I have to the right are some of the ways that this presents in kids. When kids are stressed, people in general, but particularly kids, they experience intense, often negative emotions, and they're very reactive. They're irritable. Little things that they should be able to ignore bother them. They're okay 1 minute and then the next they're not. They become much more fearful and anxious. They anticipate that bad things are going to happen to them. They feel bad about themselves. And we'll talk more about how that then relates to these other risk factors that we're more concerned about. They stop believing that people can help them. And then, as I alluded to earlier in talking to neurodevelopment, their very fragile ability to regulate themselves and to think through problems is overwhelmed by the intensity of their emotional responses. And at those kinds of points, the stress overwhelms their ability to cope. Now here, these are some slides from Bruce Perry, who's a child psychiatrist, who's actually done a lot to promulgate information to families and kids during the course of the pandemic. And these are specific slides that he did to reflect the dynamics of the pandemic for kids and families. So on your left, referring to a pattern of chaotic or severe, prolonged or uncontrollable stress, these are the kinds of things that you see. And certainly as a practitioner, we see in kids. And as you see there, when kids are functioning in that state, they become increasingly vulnerable to these negative outcomes of stress. Conversely, when kids have adequate supports, daily structure, food, regulating their use of media, exercise, remaining connected, getting the assistance they need, altruism, doing things to help others, sleeping well, and continuing to have goals, those are kids who are able to tolerate the stress of the current situation. I wanted to sort of close, I'm getting there, close with this toxic brew. And it seems to me to be the sort of the ingredients that underlies a lot of the crises that we're seeing in kids, again, specifically in the emergency room and on the wards at the hospital. It's this combination of anxiety, depression, disrupted sleep, unregulated technology, and self-medication. And there's this very prominent cognitive model of depression, which involves learned helplessness and hopelessness, which reflects back on the diagram in this picture as well. At some point, a child, a young person feels that not only are they unable to affect change, they have no agency, that there's no prospect that they'll be able to. That and in their world, that is a deficit in themselves. That's not because the world is unfair. It's because I have failed in this task of growing up. It's referred to as learned helplessness and hopelessness. And it's important to understand that there's a very, very distinct relationship between the development of those kinds of thoughts and emotions and technology use. And it comes through sort of two processes. One people probably have already heard of is doom scrolling, which is this sort of over-focus on, sort of obsessive over-focus on negative news. And the other one is very interesting, is something called co-rumination, which is defined as an excessive focus on problems in close dyadic relationships with peers. So these kinds of relationships feature things like frequently discussing problems, encouraging each other to talk about the same problems repeatedly, focusing on negative feelings, and speculating about problems in general. So you can imagine this is a process of contagion. Birds of a feather stick together, that as kids interact and as they define themselves relative with who they interact with, they become more alike. And in the absence of any kind of counterbalance, this can become quite a sinkhole for kids. And lastly, the point I want to make is the disrupted sleep. one of the things that's impressed all of us is how whacked out kids' sleep is right now. Circadian cycles that are completely flipped around. And it's important to recognize that disordered sleep is very, very distinctly and broadly associated with a range of psychiatric disorders and cognitive dysfunction. And we know that that is very powerfully related to technology use. You know, 3/4 of kids go to bed with their phones. And so there is an intersection of all these different things in creating or putting a child risk for frank disorder or anxiety. I'm going to stop there and leave up this slide in case somebody wants to talk about that. I'm a little over and I apologize.
It's all good, no worries. We have few questions that I could go through if you would like. One of to start with fun question, I guess, people wanted to know what was your favorite plant, given your interests?
Wow.
You don't have to choose one.
Okay, I'm going to say it's called the Colville's Columbine.
Okay.
And it's a white columbine that you only find above like 8,000 or 9,000 feet elevation.
Oh, okay.
So I like to hike and hunt
Nice.
for Colville's Columbine. And if anybody wants to know the secret locations, I will share them later.
Love it. Some questions in the Q&A. What are some methods that teens, young adults can do to cope with chronic stress?
Oh my gosh, they just gave it to me right here. And here we are on my last slide. And I'm going to go through this very quickly. The first and foremost is understanding what you can control and what you can't. And focus on those things that you can control. Practice self-care. And I mean that in a very mindful way, that you set aside self-care. I don't know, people think that that's, I don't know, indulgent. But self-care is taking time to do what you need to do for yourself. And the first step of self-care is taking care of the basics. I had a young man in my practice for a very long time, and he referred to this as all systems go. And it had to do with diet, it had to do with sleep, it had to do with exercise, and it had to do with setting aside time to do things that you enjoy. And granted, kids are finding that difficult, but kids are also finding really creative ways of making themselves happy, finding new ways of doing this. It's very important to practice compassion for yourself and others. Kids have a really virulent form of FOMO, right? They're very focused on achievement. They're focused on building their resumes. And they have this idea that everyone else is doing something they're not, and that they're going to lose, that they've worked so hard and it's not going to happen. They need to give kids and everybody needs to give themselves a break for doing the best they can, because we're only human, and that's what we can control. Is the possibility that every day has the potential to be a good day. Structure is very important. And in particular, we recommend a particular way of setting up structure, not only just using schedules and that sort of thing, but setting up your schedule that you do the thing you don't want to do first and you reward yourself. You'll find yourself to be much more focused and more efficient and find it much more easy and find that kind of rhythmicity creates a sense of predictability and consistency and certainty that alleviates anxiety. We talk about constructing a coping menu. When you are very, very upset, you're not thinking straight. And at that time, it's really good to have, when you're doing well, to sit down and write down the things that the options you have for making yourself feel better. so that when you're very upset and you can't bring them to bear, you can pull that out. Some people, one young lady we have in our clinic has what she calls her COVID coping box. And she has filled that with things that make her laugh, things that she likes to do, things she likes to look at, photographs. And she opens this box. It's like her little Pandora's box to make herself feel better. Another kid has what she refers to as an inspo board, and puts all this stuff up there like her own personal Pinterest. And lastly, I'm going to make this point about this reaching out and connecting to others. And I know that that feels very important. But one of the key features of resilience is being able to ask for help. And what we see in the kids that we see in the hospital is that they can't do that. They can't do that because they believe they won't be taken seriously, that they'll be invalidated, that no one can help them. And I think if I would say anything to kids, it's that find those people that you can reach out to and do that and stay connected. Related to that is this idea of helping others. I think all the doctors in the audience will tell you about compassion gratification. It's this idea that helping others makes us feel better. And so that's a really important thing. So there's one question. Do we have any more?
Yes, we do. It's to follow up with that question. There was a question by Bonnie who asked if you don't mind sharing some creative ways to connect and fight against social isolation and mental health symptoms, given that there's so much restriction at this time.
Okay. So I'll tell you, one of the things we're talking to teachers about is creating smaller groups of the class that get to interact more directly. Zoom is very passive. I mean, it's the whole idea that you would talk to a whole group of people and never see them is very odd. And so having teachers break groups up. I mean, so this isn't just the child's job, it's everybody's job, so to speak. But along those lines, this is, as much as I talk about the potential evils of technology and media, this is a point in which we are encouraging parents to be lax and allowing kids to not without monitoring, but to use media to stay very connected to their friends. And doing that in a sort of an ongoing, silly way, the way you would if somebody was just sitting there with you. Kids get very creative about playing virtual games, including virtual chess or online, multiplayer online games that allow them to stay connected. And I'm going to say the other thing that we really encourage is socially distanced, adequately protected personal contact. Bike rides together, distance walks, walking the dog at a distance, being very creative about actually being with people. There's just a lot of kids will say that I've spent so much time on social media I can't even look at it. They hunger for a human connection. And so finding creative ways to do that is really important too.
Thank you, Dr. Kraus. The next question is, in regards to mental health, what resources can adults and children utilize in order to get the help they need? For instance, referring them for therapy sessions or other methods we can use to support them.
That's really hard right now. Just as kids were dumped into online school, mental health providers were dumped into telehealth. And with varying degrees of success. Some groups are up and running, providing health through video. Unfortunately, a lot of the big, Kaiser is doing that, our clinic's doing that. I know a few other providers who are doing that, but a lot of people basically kind of shut down their practices and or are not taking new patients. And some of the larger systems have yet to develop the capacity to do anything but connect to people by phone. So it is in fact very hard right now. And one of the things that I'm going to append to my PowerPoint is a list compiled by a collaborative within the community that describes a whole range of resources, everything from housing and access to food to suicide crisis lines, numbers to call. Unfortunately, what we think of as being care as usual is difficult to access. And so with that said, I think it is hard, but there are resources. If you have private insurance, the best thing to do is to call your insurance. Because I believe some of them are trying to compile lists of people who are taking clients and have access to telehealth.
Right. I know we're running out of time, so I'm going to try to go through a couple more questions.
Okay.
One of them is, as a doctor, how have you practiced self-care despite being so busy all the time?
Well, you know what I've done? I have tried new things, including doing the mini medical school. I've been asked over the years to do this, and I always felt that I was too busy. So this was one of the things that I've done. I am cataloging my pictures of plants and looking at pictures of flowers that I've taken all over the Sierra brings back happy memories to me. I probably had COVID back in March, so I've not been exercising much, but I look forward to having clean air and being able to do that. Yeah, so it was doing things that I had put off forever, and then trying some new things that I hadn't done before.
Yeah, I think that's something that I think a lot of people are trying, doing things that they had put away, were waiting to do. They're trying to do them now so that they have something positive to look forward to, given all the stress at this point. How long did your education take you? I'm really interested in child and adolescent psych, but I don't know how to approach it.
I had 4 years of college. You probably can't tell, but I'm older. And I completed my training in 6 years. Completed adult training and then 2 years of child. Now child is condensed, and you can do both your adult and your child in 5 years. So that's a total of 9 years of training. And I have to say, I've been practicing a long time now, and I love child psychiatry. Even when it's tough, I never struggle with the sense that anything I'm doing is futile or unimportant, which is a lot to say for, the profession that you have through your life.
Yes, totally. I think I always try to remind people that even though it seems like such a long time, it flies by so fast.
Yeah.
I've going through undergrad and then medical school and then residency and now starting as a faculty, which I'm very new at this, but time has flown by. It was kind of like you start the first day and then you're done. And you're like, what have I learned? What have I done in the last so many years? But it's pretty interesting.
Yeah, I wasn't particularly fond of some of the pre-medical requirements in college, but once I hit medical school, I loved it.
Totally. I think there's some other questions, Dr. Krauss, if you would like, maybe in Q&A, I think you're able to access it. If you don't mind responding to them, answering them for us, and we'll
Sure.
have everybody take a break for 5 minutes or 4 minutes before we come back for Dr. Mcmillan's talk, if that's okay.
And my apologies to Dr. Mcmillan.
No, we still finished on time, so we're good.
Oh, okay.
Yeah, 4 minutes of break, and we'll start exactly at 6.
Okay, very good.
Yes, thank you. James H. Cullen College of Medicine, where he also served as a chief resident afterwards. So of course he's trained in internal medicine, psych, hospice, and palliative care. So a lot of different aspects of medicine, which is pretty amazing. He is the palliative medicine division chief. He appreciates the interfacing with other subspecialties in ways that create better patient care and overall better quality of life. And we, of course, working in the emergency department, and I'm sure inpatient medicine, pretty much everywhere in the hospital, we do really appreciate his services and his team's efforts to help us out as much as possible. It's end-of-life care and palliative and hospice, everything is very important, and you realize that once you start to practice that it's as important as talking about birth and everything else. It all goes hand in hand. So it's pretty amazing. I will let Dr. Mcmillan take over and go from there.
Thank you so much, Dr. Dillon. I'm Patrick Mcmillan, and I'm so happy to be back. It's been a long time. I was beginning to get a little insecure. I've done 4 of these talks. This will be my 4th talk, rather. But so anyway, I'm happy to be back. And I appreciate the introduction. And you said an interesting fact. I think I've got one. And you said something about being famous. I thought I was already famous because this is my 4th time speaking at the Mini Medical School lecture series. So I thought I was already
famous.
If I would be famous, I'd be a rock star. Believe me, that's my that was a dream of a lifetime, and I'm sad. I know there's probably a lot of young people out there who don't know who Eddie Van Halen is, but Eddie Van Halen died today, and that's a sad day for me. Great band, Van Halen. It's funny you mentioned an interesting fact. This may be a morbidly interesting fact, and I'm sorry to be so indelicate at a time like this and at a venue like this, but the last time I spoke at the Mini Medical School was 3 years ago, and during that lecture, my mom died. So my mom was 92 years old, and one of the greatest people in my life. And so so I've thought, man, I've got my phone handy here. So if I get a text and I have to stop the lecture, it'll be because of one of my family members. So I've had a little bit of phobia about speaking. I'm joking. My mom was a real jokester. And so hopefully I'm not being too weird at a time like this. And so I probably could have done this with my PowerPoint, but I did want to show a picture. I don't know if you can see it or not, but I don't know if you can.
Oh no!
It's a picture of my mom and dad when they were really young, and so my mom and dad both. Again, I never treated my mom. Actually, I did treat my mom at the end of her life, but they both had depression. My mom probably had anxiety more than depression, but she was treated for depression. My dad certainly had depression. And the reason I'm mentioning that is that I think there's, and what we're talking about today, my talk is psychiatry and the geriatric patient, but it's mainly about depression and grief. And whoops. Going to work? there it is. By the way, I have no disclosures. But what we're going to talk about is depression and the geriatric patient. Look at normal grief versus complicated grief and depression. But certainly my mom and dad, and they were from the generation. My parents were old when they had me even, so they were of that generation, the so-called greatest generation. And those there's fewer and fewer of those people around, but I think they probably went undiagnosed quite a bit. So I think this talk in some ways is relevant to my mom and my dad and people of those generations. And obviously, people of the baby boomer generation, my brothers and sisters are in their 70s. I mean, and heck, I'm over 50, so I'm elderly now. So I'm probably talking about myself. I think I'm considered elderly. I could sign up for AARP now. So anyway, I think I'm considered elderly. So I might even be talking about myself. And so maybe I'll diagnose myself tonight. We'll talk a little bit about pharmacology and treatments in the geriatric patients. And then we'll look at I know that, again, with the pandemic, I think there's a lot of interest in what's going on in depression in the elderly during the time of COVID-19. So I'll try to touch on a little bit of that as well. And hopefully we can have an interactive session. So we'll start off with a question. I love questions. And this one, I'll start out as a 75-year-old male comes to your office and tells you he's feeling okay. He shelters in place, which means this is during the era of COVID most days, but goes to the grocery store. He follows his grandkids on Facebook daily, which these old people are pretty remarkable. Now, I say old people, I'm sorry, I don't mean to say it like that, but elderly folks, I mean, they're just amazing to me. I had a neighbor across the street. I should have brought her over here. She's 89. And I mean, she's just amazing. She drives and, she does all kinds of things. And I may actually talk about her a little bit later when we talk about grief, but she's on Facebook and she does all kinds of crazy stuff. His wife of 55 years died 6 months ago, and I'm going back to the question now. He misses her and thinks about her each day. He sometimes hears her voice when in the house. His sleep patterns are at baseline, meaning they haven't really changed much, and he's hoping that he can see his family when the virus gets contained. So what is the most likely diagnosis? And I think Summer and Dr. Doolan is kind of manning the chat, but is this major depression? Is it a delusional disorder? Is it ongoing grief? Is it schizophrenia? Or is it COVID-19 psychosis? So I'll give everyone a chance to chime in, and I think people are going at a rate. Do you want me to go and just wait until people keep going in, or go on with the lecture?
You can wait if you want to.
Quite a few people have responded.
Oh, wow.
And
The numbers are just moving in.
yeah, they're saying ongoing grief, seems to be the answer.
See, I don't even think I need to give this lecture to you folks. You guys are too smart. I was hoping someone would take COVID-19 psychosis, but
There was one person who said it.
yeah, there's always a joker in the crowd. I mean, this is, again, and we'll talk a little bit about grief, but yeah, this is a grief situation. We'll kind of spell out the differences between grief and depression and different things. And again, I think one of the things that I remember when I first learned about grief, and my neighbor, I talked to her about it all the time. Her husband died about 2 years ago, and I knew him real well, and I talked to her, and I do this, but sometimes people they'll hear the voice of their loved one. I mean, imagine living with someone for 50 plus years. I mean, I've been married for almost 28 years, and it's just hard to imagine being married for 50 years. And my neighbor was married for almost 70 years to her high school sweetheart. So anyway, it's grief, and we'll talk about grief and depression and so forth. So what we call this is late life depression. I mean, that's basically what the medical society calls this. But again, it includes both aging patients whose depressive disorder presented in earlier life and those who have a first-time diagnosis in later life. So again, there could be folks who have pre-existing depression at an earlier age, or there's some people that just something happens later in life, and there's all kinds of different traumatic experiences, loss of a loved one is a huge one. And so these kind of things can affect people differently. Depressive illness in the older population is common. It's a serious health concern. It's, you know, it affects a lot of people. You know, concern that is associated with comorbidities, you know, impaired functioning, excessive use of healthcare resources, and again, increased mortality, including suicide. Okay. You know, most people feel like late life depression is underdiagnosed, and I think it's true. I don't think, you know, my parents weren't really diagnosed with depression ever. You know, sometimes sometimes there can be, you know, alcohol or substance usage that can mask these things, but I think it goes underdiagnosed. I think we, you know, kind of say, oh, that old man's just getting cranky. Or, you know, you know, whether it's a female, there may be some, you know, symptoms that show up that don't look like classic symptoms of depression. Now, in our country, the older men, older African Americans and Hispanics are at even greater risk of unrecognized depression for the reasons I just mentioned. We're just gonna say, oh, he's just getting old and cranky and crabby, and we gotta have all these labels for folks. But the public health consequences of inadequately treated depression in late life will increase over time as the population continues to age. And remember, you know, if a patient who has diabetes, heart disease, all kinds of any kind of comorbid medical conditions, remember that, you know, if they're not taking care of their medical conditions because of depression, that can lead to, you know, further medical issues. So the two are intertwined, I believe, mental health. And this was basically why I got a combination training in psychiatry and internal medicine. That was one of the reasons why I did it. I just thought, you know, you really can't extricate the mind or the soul from the body, I don't think. I mean, maybe, you know, again, I'm not a priest and I'm not a spiritual person, but I'm talking about, you know, in life, you know, when we're walking around, talking. I don't think you can, you know, extricate the two. You know, the mind and the body are linked. So over 80% of mental health treatment for depressed older adults is delivered in the primary care setting. And I gave this lecture initially to primary care doctors. And what I used to tell people, again, I was a trained psychiatrist, is that, you know, and I used to, you know, talk to internal medicine residents and other folks in the medicine field, family medicine doctors. And, you know, essentially they're going to see and treat more depression than I will as a psychiatrist, because as a psychiatrist, I would actually see the depression either in the psychiatric hospitals, you know, from a suicide attempt, you know, when the depression becomes major depression, or, you know, the primary care doctor has done all he can or she can, and they need our help. So, but a lot of times folks can get treated and in the primary care setting, but unfortunately it goes undiagnosed. You know, I mean, sometimes you're supposed to, you need to look for other things, but I think sometimes as medical folks, we tend to forget the mental health aspects of folks. And we start looking at, well, is it a thyroid issue? Is it anemia? I mean, there's all about vitamin B12 deficiency, and those are all things you should look for. But I think you should also, if those things are eliminated, you know, and sometimes you can even misdiagnose people with dementia and they're depressed. You can misdiagnose dementia with depression too. So I'll talk about that a little bit later. So again, recognition and management of late life depression is an important responsibility for the primary care clinician. So for all of us, but especially the primary care folks. And again, you can use, what we call pharmacotherapy, which is medications, or psychotherapy. Again, cognitive behavioral therapy works wonders. I used to work with folks, and I actually saw a patient when I was a psychiatry resident, and I did something called cognitive behavioral therapy with some people, and also did something called interpersonal therapy. Now, again, it'd be hard for a primary care doctor to do this, but I basically talked to this gentleman for a while, and we just identified something in his life that happened as a young person. He's the one that brought it up, but we just really focused on that and tried to resolve that. He was about a 65-year-old man. He had bipolar disorder. underlying bipolar disorder and more likely bipolar depression. He also had some remote history of substance abuse, but that type of therapy really helped him. And it's a limited therapy. You probably have someone in your office for, maybe 6 to 12 sessions. And hopefully you get to some kind of resolution and that person can move on, and it seemed to benefit this person. So this is just some data, just some statistics and just to kind of get an idea of, how prevalent, major depression is. And again, lifetime, prevalence of depression among individuals is 15%. So, that means, overall people with depression over time is again 15% over their lifetime. Now, when you see a range of 30 to 70% genetic, that tells you that it's probably, depression is genetic, but it's also situational. Psychiatry has gotten really fancy over the years, and there's all kinds of genetic tests now that can tell you, if your patient will benefit from a particular drug for depression. So there's all kinds of fancy ways and basically one of the simplest ways, though, if I had a patient who took a medication, who was depressed and they had family members who had depression, I would always say, hey, which medicine worked best for your mom or your dad? And so I would just kind of cheat that way if I couldn't afford, if the insurance didn't cover those fancy tests. But here's a statistic that we all need to pay attention to, and that's 15% of patients with major depressive disorder. And again, we'll talk about the criteria here in a minute, but they'll actually kill themselves. So suicide is very risky, especially in older, white, educated, divorced man. I mean, that's a real risk factor. And so, you have to really be careful. And you can see the differences between females and males. And remember this, please. 60% of depressed patients also have an anxiety disorder. My mom was probably in that category. I mean, she was a pretty, interactive person, but she was, probably had some social anxiety as well. But she certainly had some depression. I remember my mom. She lived in South Dakota. I don't know if we have. I'm sorry, North Dakota. I don't know if we have anybody from North Dakota here, but she said one time the sun didn't shine for a month, and she admitted that she was depressed. And again, seasonal depression is certainly something that's prevalent. That's why I moved out to California. The sun shines all the time, except right now during the fire season. The prevalence of depression in adults greater than 60 is, again, roughly the same as you see in the general population. So it's there, it exists, and we need to be careful. So these are some risk factors for late life depression. Again, women, social isolation. Again, I look at chronic illnesses. I mentioned that earlier. Again, folks that are widowed, divorced, separated. Also grief associated with the loss of a loved one. I think about those kind of things. Again, and frailty. Again, folks that are kind of cooped up a lot. And again, honestly, a lot of people are really cooped up right now, whether it's in a nursing home or it's in their house. I mean, I think people are beginning to, make some, calculated risks, maybe, which, again, I think is probably okay. But, if you've got a family member that's got a lot of comorbid medical conditions, meaning they're diabetic or heart failure or things like that, you have to be careful, lung diseases. But people with pain and some, and again, a lot of elderly folks have pain issues. And I've seen a lot of, folks come in the hospital and say, if you don't treat my pain, I'll kill myself. I mean, I've actually heard those statements, and I've had to admit people for those kind of things. So, obviously, I don't think they need to be in a psych hospital. I think they just need to get their pain controlled. And honestly, I think it's again, I think there's an opioid epidemic, but I think sometimes we're, as medical people, we need to be careful, not to say, well, we can't give pain medicine. I mean, because again, you're limited what you can give elderly folks. You can't really give them ibuprofen. You don't want to, cause them to have a bleeding ulcer or kidney failure, things like that. So sometimes a very low dose of Norco for someone who has chronic pain Those calculated risks, I think, are beneficial. And obviously cognitive impairment, functional impairment, cognitive impairment being dementia. Dementia and depression go hand in hand. So here's 5 or more symptoms for 2 weeks is major depression. So if you looked at this, you have to have a depressed mood or loss of interest. And again, any one of these, any 5 of these symptoms, especially, when you're looking at recurrent thoughts of death, I don't care if they have 2 symptoms, they're majorly depressed. And again, sleep disturbance can be sleeping too much, not sleeping enough, poor concentration, weight change, could be loss of appetite. Sometimes people have what we call, melancholic depression, where they eat a lot and they have different types of sleep patterns. And also remember, folks that have strokes, older people have strokes. And there's a lot of good evidence if you have a stroke on the left side of your brain, meaning your right side of your body is affected, but if the left side of the brain is affected by the stroke, particularly the middle cerebral artery in that area, that can affect the parietal lobe. Those areas of the brain, when they're affected, you can get depression following a stroke. And again, it's that part of the brain. Plus, think about what happens to someone who has a stroke. I mean, their life has changed quite often. What they can do for themselves is a lot different. I always tell people, look for signs and symptoms that are unique to the elderly or older patient. Again, irritability, like my dad. I mean, my dad was just, gosh, he was a grumpy old guy in a lot of ways. I mean, my dad was a good guy, but he was grumpy. But, I think it was depression. And so you have to, think about those kind of things. If you ask an old man, hey, are you depressed? He'll probably, yell at you. But if you say, hey, have you been more frustrated or irritable, and you can see this in folks. So you just have to, be on the lookout for that. And I'm not saying every irritable person out there that's old is depressed. I'm just saying you have to look for those types of signs. Again, obviously low energy, they don't want to do things, their motivation goes down. And again, somatic symptoms and what you might think is they're just, their body aches, stress, all kinds of, muscle tension, things like that. But again, you could easily say, well, this person's just getting older, and it could be depression. So again, you have to dig in and find out, what's going on. Also, as I said, what we used to call this pseudo dementia. They don't call it this anymore, but we used to call it pseudo dementia. I saw a patient once in the VA. This was a woman too. I trained in the VA back in 2004 and through 2009. You rarely saw any women there in those days. But this woman, when I got done with the exam, I thought, this woman, she looked and sounded demented, but it was depression. It was major depression. So, and again, I mentioned this earlier, metabolic issues, B12 deficiency, those are all real things. So you want to rule all those things out, especially in the elderly. I just got a text, so I'm sorry, I had to look over there. So this is there's different screening tools that we use for trying to differentiate depression. And again, there's the two question screen. There's a geriatric depression scale. We have something called the PHQ-9, which is a good exam in the clinic, not very good in the hospital. You can get some misleading information. But the one here that I want to highlight is the geriatric depression scale. And I've tried to, I hope you can read the table, but basically, are you basically satisfied with your life? Do you often get bored? Do you often feel helpless? Do you prefer to stay at home rather than going out and doing things? Do you feel pretty worthless the way you are now? So 2 out of 5 of those questions, if you answer it yes, then they're considering that depression in the geriatric patient. Now, you always want to differentiate grief versus depression. And, used to be when I trained that, you really didn't want to sort of treat grief as depression, but, obviously, grief is a natural response as it says here, including thoughts, feelings, behaviors, and, physiological reactions. But again, bereavement is a real thing. But there is something that we used to call it pathological grief. A more, I think, compassionate term is complicated grief. And that's, a prolonged, very intense and like it says here, disabling type of, grief. And these are folks that say, I wish I'd be better off dead now that my loved one's gone. There's all kinds of things that people say that give you, sort of a clue that this is a little something different than regular grief. And in that, that question we had earlier, this person was looking forward to doing things, but if the person is not looking forward to doing things, then you're looking at probably complicated grief. Again, it's controversial, like I said, to kind of diagnose depression along with grief. But, again, there's the 5th edition of what we call the Diagnostic and Statistical Manual of Mental Disorders. It's kind of the Bible in psychiatry. Again, it's probably overused. And honestly, it's, I think you end up labeling people sometimes more than actually thinking about what's going on with people. But anyway, it did this DSM-5, as it's called, came out about 5 or 6 years ago. And I think it looked at, basically treating patients with depression, even though there was still some grief associated with it. Okay. Just real quickly, I'll just go through some, this SSRI is a selective serotonin reuptake inhibitor, but these are some of the medicines. I'm sure you're familiar, you've seen these, but, basically a couple things I wanted to go over is just a side effect profile. Now, these older and newer antidepressants, as they are, have some side effects, and usually they're GI, sexual side effects, or sedation. So again, remember, side effects will occur. And again, you always want to think about the time and that you have a patient on it and maximize the doses. And some medications take longer for them to become therapeutic. So one of the, and these are some different drugs that hit serotonin and another neurotransmitter called norepinephrine. And it's really kind of, these drugs work by basically inhibiting the reuptake. I mean, you and I are both, you guys might not be secreting serotonin right now. You might feel depressed listening to this talk, but so your serotonin levels may be low. But if you were taking Prozac would make that serotonin really hang in those what they call synaptic clefts in the brain, areas where they would bind to receptors. So these drugs, duloxetine or Cymbalta, Effexor, these drugs stimulate 2 different neurotransmitters, which are known to be depleted in depressive states. And there's some other new drugs like this drug called vilazodone, which is, has less of a sexual side effect and GI side effects. And again, I think I used to think, well, it's an old person, who cares if it affects their sexual, sex. But again, that's not true anymore. I mean, you can't think about those things. I mean, I used to have people who were 60 and 70 coming in my office and asking for Viagra and all kinds of things. I mean, I used to always feel bad for the ladies. I mean, I had some, I used to think, you think a lady would get a break after, she's 70, but, with the advent of Viagra, these guys are going after things now. But I mean, that's sort of a joke, but I think, a healthy sex life later in life, it shouldn't be just assumed that people that are elderly don't have an active sex life. So you do have to think about these things. These are some other drugs that we use. Wellbutrin, again, I use Wellbutrin in young people just simply because of the sexual side effects. I mean, young people, if you give them a drug that causes sexual side effects, they will they'll stop taking them. Remeron, again, we give this to older folks because it helps with appetite, and it also helps with sleep. I think sometimes, people just sometimes, I think without thinking about it, put older people on Remeron. I don't know that, I think you have to, really select your antidepressant more carefully than just saying it's an old person, put them on Remeron so they'll eat and sleep more. Trazodone's an older antidepressant, which was not good for depression, but it's good for sleep. I always include it. the thing I want you to pay attention to is to think about a tricyclic antibiotic, these TCAs, amitriptyline or doxepin. They're good drugs, but I avoid them in older folks because of the side effect profile. It can cause cognitive effects, dry mouth, all kinds of different things, but particularly the cognitive effects. So I usually avoid these tricyclic antidepressants or TCAs in geriatric patients. So I'll spend a little bit of time just going over depression and the elderly and COVID-19. And again, obviously there's a lot of psychological distress, going on right now. I mean, there's patients, in assisted living or nursing home facilities. And, and again, I don't know what they're doing right now, but as far as I know, they're still not letting folks go in. They're just so worried about these, COVID-19 spreading situations that, they kind of keep folks out of nursing homes. So I don't know what exactly they're doing now, but I know early on in the pandemic, I mean, family members, it was sad. You saw a lot of pictures of people looking at their family member through a window. So, I think it really has. And I've talked to a lot of patients, families, and these folks, the elderly folks end up in our facility. And I've heard patients say they were doing well. The families would say, well, they were doing pretty well. We were going there regularly. Once the pandemic hit, something just happened. And so I think that interaction with family is so critical for the elderly. And I think, it probably did lead to a lot of depression. Obviously, my mom was in a nursing home for the last 2 years of her life. And, we provided, and again, my sister was a nurse, I'm a physician. We had to provide oversight, even though it was a good nursing home and everyone loved my mom. They treated her like a queen. But, again, they have a lot to do there. So family oversight is real critical. So, not all geriatric patients are going to react the same way to stressors. And so, I'm sure that there's I'm sure there's a lot of folks that they've done just fine. I've got a good friend back in where I'm from in Indiana, and he's got a history of depression and post-traumatic stress disorder. He's a Vietnam veteran, but he loves staying at home. I mean, he hasn't been affected by this at all. His daughter comes and, I think cleans the house once a month or something for him, or makes him change, so she can come in and change his sheets and feeds him and stuff like that. But other than that, he's by himself and sees people through Zoom and his doctor's appointment. So he's reacted really well. So, again, everyone has their own, reactions to stressors, but I think COVID-19 really has increased, statistically, depressive episodes. So again, those infected with COVID-19 are at an increased risk of depression as well. I mean, obviously being in the hospital. Again, I've seen people with PTSD that get into the hospital and in the ICU as well. So we're at a question. So I think I'm actually doing pretty well on time here. So we'll go with this question. A 62-year-old female comes to your office with her husband. Her husband reports she is more forgetful. She reports poor concentration, fatigue, and has stopped playing bridge with her friends. Her appetite is fair, but she eats only half of her meals. She admits she is clumsy with dates, but is able to tell you the name of the president. She is diabetic and takes metformin twice daily. Which diagnosis do you wish to explore further? So basically, again, as physicians, especially internists, we love thinking about every known possibility, even if it's slight and remote. So we always have to keep things in perspective. But what do you guys think this is? A, B12 deficiency, B, depressive disorder, a C, a dementia process, or D, all of the above? Do you want to explore one or all of the above? What are we looking at, folks? What's the consensus here so far?
Like D, mainly D. Some people said A, and some people said C.
I love it. Oh, you guys are so smart. Oh, look, I tell you what, sign up for medical school. You guys are all shoo-ins. I'll take you. I mean, look, it could be any one of these, right? And I actually wrote this question, and I threw in the metformin just as a little little Easter egg, as it were, a little surprise. Metformin, remember this, please. Almost 50% of my patients in the, again, number one, diabetes is a risk factor for depression. Not everybody, but it's a risk factor. But if you take metformin, there's a high chance you'll have B12 deficiency, and it's overlooked quite a bit. So when I was in private practice, I say private practice, I was doing internal medicine in a clinic situation back at East Tennessee State University, but I always check my metformin patients for B12 deficiency. So yes, basically, elderly folks, they don't have a reason to remember that. I don't remember the date half the time. I mean, I go around with medical students and they're like, oh, this person's demented. They think it's 2019. It's like, well, that's pretty dang close. Or if they say if they told me it was September, it's like, well, it was September 5 days ago. That's still pretty close. I don't remember the date. The only reason I know the date today is because Summer put something in my calendar that told me I had to come someplace to speak. And that's how I keep up with my dates, because I have to be somewhere. So again, all the above. You have to really think about all of these different processes. At 62, again, that would be very early onset dementia, but it happens. People get dementia. I mean, honestly, I made a mistake once. I diagnosed a man with depression once. I was a resident, so I wasn't, quite finished with my training, and it was in an internal medicine clinic, and it was a friend of my preceptor. He knew the guy really well. But this guy ended up with Alzheimer's dementia. He actually became my patient later on, after my mentor left. He became my patient, and I treated him, and he was treated for dementia. He had Alzheimer's, and it was fairly early onset. So think about all those different things. So in conclusion, again, you want to diagnose and treat depression in the geriatric patient. Again, look for irritability as a sign. Remember my dad. Remember John Mcmillan. If you're ever, believe me, I love old cranky men. And I bet Dr. Kraus could, she could tell us some more about old cranky men or young cranky kids, maybe even. But again, what I call atypical signs. Again, make the proper referral if needed. If you can't treat it, if the primary care doctor can't treat it, then get them to a psychiatrist, get them to a counselor. But again, get it looked into. And again, remember the medical issues that predispose or mimic depression. I think that's it. Do we have any time for any questions?
Yeah, we totally have time. We have a few questions that were put in. I can read a couple of them. First of all, a lot of people knew about Eddie Van Halen, so that's good. So you're not alone, so that's good. And then it says, what are the best ways to cope with grief? Somebody in the audience, Luis Vargas, they mentioned that they just lost a loved one recently. So what would you suggest is the best way to cope with grief?
With grief, realize that grief for everyone is individual. I think it's an individual process. Support the person. Don't be a helicopter kid. Give them space. Let them be themselves. But pay attention. And I think validation is one of the things that I believe in when it comes to grief. And the other thing too is, I was in this course. There was something called Healing Arts, and it was created by a physician she's up in San Francisco. And but anyway, one of the things I learned at Healing Art course is like, what are the worst ways to support? So think about it this way: what are the worst ways to support people in grief? And you say, hey, my mom died. Well, how did she die? You say things like, well, how did she die? Well, she's in a better place. So I would avoid those kind of statements that like, well, if somebody said that to me, I'd probably tell them to get out. Because when you're in a grief situation, it's just, hey, I'm sorry for your loss. And sometimes saying I'm sorry for your loss seems kind of like a weird thing to say, but I would just, just support them. And, and if I know with our neighbor, she had a hard time eating. So my wife bought me this pizza. So maybe you should go out and buy this too. I got basically a oven for my grill, and I make pizzas all the time now. And started taking pizza over to her all the time, and she didn't really like eating much food, but she liked this pizza for some reason. And honestly, it's really good pizza. The ingredients are good, but yeah, just watch them, validate them, feed them if you can, but don't force them to eat.
There's a question about how I would love to hear about treatment of anxiety in elderly patients, since benzos can be dangerous if they're on other sedating agents.
Oh, I love that question. Listen, I'm a big believer in benzodiazepines for everyone. Believe me. No, I'm kidding. I know that I know Craig's back there. He's probably thinking, man, this guy should never practice psychiatry again. How you doing, Craig? No, very valid question. Benzodiazepines are probably off limits. And again, you want to be careful of benzodiazepines anyway. What I would recommend is using some SSRIs, these selective serotonin medications. Again, if you want to use things like cognitive behavioral therapy, relaxation, get them an app, the calm breathing exercises. If you want to do something non-pharmacologic, massage, acupuncture. There's all kinds of things you do that are non-pharmacologic, but some of the medications that I do recommend that I think are well tolerated are drugs like, and I listed them, escitalopram or Lexapro, Celexa, at low doses. And again, I always recommend starting off with low doses of medications.
There is a question about what are some symptoms of teen depression. I'm sure both you and Dr. Kraus could tell us about that.
I'll just say that the symptoms of depression in kids are the same as the symptoms in adults. I do think kids at times tend to have more atypical features in terms of rather than appearing distinctly sad or melancholy, they may be intensely irritable and have very low frustration tolerance and cry, but often it's in the context of you're making me angry or you're frustrating me. The other thing is that kids may be more or less likely to sleep excessively and or eat more. It's fairly uncommon to have a kid who has a substantial loss of appetite. More often, kids will eat particularly carbs as a way of trying to soothe themselves. I think the other thing that's interesting, and this sort of comes up in the context of talking about the pandemic, there's this phenomena of mass depression in adolescents, is that if you think about an adolescent's personality as being in development, they may or may not have some baseline of themselves from which to say, this is not me. This is not normal for me. I am this way, but now I feel this way. I must be depressed. So they're very inclined, and if you don't have an explanation for how you feel, you look out at the world. So these are kids who will come into your office and appear sullen and quiet, and you know they have disturbed sleep and their grades are falling off. And then you say, well, what's going on? It's like, how's your mood? Well, my mood's horrible. Isn't your mood horrible? Are you aware of what's going on? Of course your mood's going to be bad. What do you expect? My mood is normal because the world sucks. That can be a presentation of depression in kids.
Yeah, that totally makes sense. And then there's a question about Ella asked, she said, I always thought depression was a person being super sad and never really understood the true definition of depression. What is the true definition of depression? Also, how does emotion make people sleepy, motionless, etc.?
Well, that's a good question. That's a complicated one. But again, sadness is, I think you have to differentiate sadness, from grief, there's people that are sad I was sad about Eddie Van Halen. It just, when someone told me I was sad, I mean, I was just like, literally, I was at work and someone said, "Hey, Eddie Van Halen died." And I just was like, I'm sure a look of sadness came over my face. Again, depression is, like I said earlier, again, I mean, when you're talking about, the psychiatric diagnosis, but again, it's a loss of interest and it's a depressed mood. It's basically, it's composed of all those different symptoms, but it's basically when you have something called anhedonia, which is a loss of interest. I think that's the main thing I look at, is a loss of interest in things that used to bring you pleasure. When that happens, I think and for an extended, again, for 2 weeks or longer, that's depression. And the second part of the question, how does emotion make people sleepy or motionless? I mean, again, when you're sad or when you're depressed, I mean, and I think that's why I treat people with medications. When people come to my office, and they're like so depressed that they don't have any motivation. They don't want to work. Their concentration's horrible. They don't want to get out of bed, things like that. And again, they develop those somatic symptoms like melancholic depression, things like that. Then that's when I start thinking about, this person needs a medication. They need to get over this hump so that they can actually start to begin to want to start helping. Because again, I think you have to participate in your depression treatment. I used to always tell people, look, I don't have any magic pills here. This pill is not going to make you happy. If you're sad or depressed, this pill can maybe make you feel like, give you more motivation to do things. But it's not going to make you happy. So that's why all the studies show that depression plus therapy work much better than just drugs alone. I hope that answers the question.
Yes, and I think it sort of feeds into the next question, like, could people self-treat depression? They talk about different types of depressions. But I think that what you mentioned, potentially, that it's medication is just aspect of it, right? There's a lot more that goes into it. Oh,
absolutely. I think there's all kinds of things you can do that can treat depression. I mean, getting out in nature. I mean, but if you're so depressed that you can't do those things, then I think that's when you need to start looking at a medication. But yeah, there's a lot of things that people can do: meditation, yoga. I mean, there's so many different things you can do. But again, things that, listening to music, being, interacting with your family. I mean, there's all kinds of things I think that people can combat depression. And there's some people that I've treated over the years that they don't want to take a medication. And I always respect that. But again, if it's a serious depression, if you don't go the medication route, then maybe therapy, because I think talking to someone, getting validation for what you're going through, because most of the time when people really get depressed, there's some kind of stressor involved. And usually when I used to admit patients in the psych units, there was always something going on. And there's a real big correlation. What I found to be true in most patients I saw in a psych hospital, they had poor coping skills, or less than average. We'll say that's a better way of saying it. Less than average coping skills, and they had very, very poor social support. They didn't have people around them to kind of help prop them up. So there's a lot of things you can do.
There was a question. With parents or siblings that struggle with depression, what would you suggest to best support them? I think that's a question.
What's that?
I think that sort of feeds into your response about the support system.
Yeah. And the question is what now? Parents or siblings that struggle with depression? Yeah. Again, like I said earlier, encourage them. Again, I think here's the thing. And there's a great movie called A River Runs Through It. And it really hits home. It hit me like a ton of bricks for a lot of reasons. But one is I realized that family members really can't help family members. I mean, you can support them, you can love them, but honestly, a lot of times people need to get help from strangers, like me or Dr. Kraus, or a good therapist, or a support group. I mean, if people are going through grief, for instance, I would recommend a support group. I mean, you know, and again, I'm a psychiatrist, but I don't think I need help a lot of times. I'm a physician. I don't think I need a doctor to treat me. I can treat myself, and that's a mistake. And I actually, my sister died about a year ago, and it was a very sudden situation that really shook up my family badly. But what we did was, and I was sad. I was grief stricken and all those things. I don't believe I was depressed, but I can tell you that not much mattered to me when my sister died. I can tell you that much. There's a lot of things that didn't matter to me much anymore. It was really hard to start focusing on things, but I did get into a grief group. And even if your family member wasn't in hospice, and my sister wasn't in hospice, she died suddenly. We actually signed up for Hines Hospice, a 10-week grief session. So again, grief groups can help, support groups can help. So, you know, again, support them by trying to be active. But I think if you try to push your family members too much, they'll resist you. And all you can do is what you can do, and just try to support them and validate what they're going through.
Thank you. There's another question. It says, is there anything you can do for people who have been diagnosed with depression and misuse their medications?
Well, if you mean by misuse, I don't know what you mean by misuse. I mean, if they overdosed, then gosh, I mean, as a psychiatrist, if someone overdosed on their medicines, they're never going to get that medicine again. However, that's just a liability thing. But, you know, again, you can always give, I mean, if you have to use medications, I mean, there's ways to, you know, work around that. But again, I mean, all these again, number one is don't give them any kind of drug that, you know, people use that really can, I mean, there's a lot of medications that people can overdose on that are fairly, I'm not saying that there's no benign overdose. I'm not trying to say that, but I'm just saying that there's certain drugs that really do affect people in a very negative way when they overdose versus some other medication. So, I mean, it's always possible that you could work with a psychiatrist or whoever's prescribing the medication to give the family member a limited supply so that they can't overdose on them. I mean, it ends up being a little bit more cumbersome, but I think there's always ways to make concessions. Now, there's also, again, I didn't talk about this, but electroconvulsive therapy. Now that's, you know, some people think ECT is just crazy and they think of One Flew Over the Cuckoo's Nest, but I actually spent a month with a psychiatrist and we were treating elderly people. I mean, when my attending hooked up these electrodes, and we were doing this in a very safe way, ECT is done so much differently nowadays than it was in the 50s and the 60s and so forth. But this woman had basically a psychotic depression. And when I saw the psychiatrist put the electrodes on her and shock this woman and cause a seizure, I mean, I knew the guy pretty well. And I thought, man, this guy's cold-hearted. And he even said it to me. He goes, I bet you think I'm cruel, don't you? I said, well, yeah, I did. But it worked. So, I mean, there's other things. There's vagal nerve stimulators, and Dr. Kraus and her crew know more about these. But there's other ways to treat depression that aren't necessarily medications. That, again, the vagal nerve stimulator is very costly. I don't really know much about the efficacy of those types of things. I had one of my, mentors back in Tennessee used to use it, but there's different ways. Again, there's therapies, there's all kinds of things. But if someone's, again, a risk for misusing their medications, then you may need to look at some other things. And again, ECT is, I'm not saying for a person that misuses their medications, ECT is an indication for that. I'm just saying there are just a number of different things out there that people can get. And ECT is basically for, really extreme depressions that folks have tried everything, all kinds of medications, and nothing has worked. I hope that answers the question.
I just want to add, the issue with kids become very complex because of the fact that antidepressants have what's called a black box warning related to concerns about treatment emergent suicidal behavior. And we know that this affects about 4 out of every 100 kids who are prescribed medications, and it really varies from medication to medication. And there are a lot of consequences. I mentioned in my talk this idea that not only has there been an increase in the rates of depression over time, when the SSRIs came out, there was a decline in the rate of suicide among teens. And that's now the second leading cause of death in the population that I was talking about. And since that time, in the absence of those medications, those rates have continued to climb again. But in that context, just as Dr. Mcmillan said, they aren't medications that work for everybody. And in fact, if a child has either a short-term or a mild or moderate, the first line of treatment is ideally therapy. And in fact, again, this idea that exercise itself exerts an antidepressant effect, effective sleep hygiene exerts an antidepressant effect. So, one of the things we do with kids who come to see us is we always focus on those things first. If we correct your sleep and your exercising, then we reassess your mood. I think there are kids, though, who present with very severe symptoms or very, very persistent symptoms that they've not been able to, such that they're not able to recover, that they're not able to get back to a state of health where we may pursue medications first, as opposed, or ideally in concert with, before, rather than waiting. And I also want to point out the other issue with medications is this question is, are they better than nothing? In child psychiatry, multimodal treatment is the standard of care, which is, you're working with families, you're working with the child's pediatrician, you're working with medications, you're working with therapy. In the real world, particularly in a community like ours that's under-resourced, sometimes you don't have all those tools available, and you have to use the best tools you can. But in general, and again, along the lines of what Dr. Mcmillan is saying, medications alone, aren't as helpful as they could be. They're an important but limited tool in our arsenal.
Totally. It's actually a very good question. Going back to sleep hygiene, one of the attendees asked, how does sleep apnea come into play with depressive states and with memory loss? Any recommendation how to get an older senior to actually use the CPAP machine ordered for the depression as short-term memory?
I tell you what, if you figure that one out, you let me know. I mean, again, these sleep, and again, I'm probably, I've argued with the pulmonologist multiple times. They're always going to say, avoid sedatives. I mean, they have the standard thing that they say for everybody. It's like, and in general, that's a good, but if you have to ask, why is this person not using the sleep, the mask? And does the mask not fit? Is it, what have you? Is the person, sort of claustrophobic? You should have to ask yourself. So I'm of the opinion that, look, if you need to give someone something that's going to kind of help calm them down at night, to get them to wear that mask, you do it. Or, again, you just find a good fitting mask, but again, I'm not saying I'm a big believer in again, using sedatives to get people to sleep, but there's again, you can use melatonin. Again, something that's going to help them sleep at night. Again, I think you have to get the right fitting mask. And if, there's all kinds of different masks nowadays. So I think that's the one. But again, like I said before, when it comes to your family and older people, if I just, like my dad, if I'd have told my dad, hey Dad, if you cross the street, you'll get $1 million. He'd go, well, I'm not going to do it. I mean, that's just how he was. He just was that kind of person. It's like, how in the world are you this unreasonably irritable? But that's how my dad was. And I think that's how some people are. And I think as older folks, as folks get older, they they know that they can't do as much as they used to. So they really fight for that independence. So I think people in general are that way. So I think, for these folks with the sleep apnea, again, I tell people all the time, and this is how I used to get people to do things. Sometimes you have to manipulate people and get their doctors to do it. But I used to tell people, and again, it's not manipulation, and it's true what I would say to the people. I would say to people who say, well, I'm not taking this blood pressure medicine. I'm going to keep exercising, and my blood pressure is 200 over 170, but it's just like that in your office, or whatever. Or their cholesterol was high. I'd say, look, you can do whatever you want. I say, but if these things that you're not treating are risk factors for dementia. And I'll bet you any amount of money that someday they're going to connect sleep apnea with dementia, because again, it's going to cause high blood pressure. So again, sleep apnea is linked to cognitive decline, maybe not dementia like Alzheimer's. I'm not saying that, but a cognitive decline or a vascular type dementia. So again, speak the person's language, talk to them, find out what their values are. There's an old saying about, I think it's what is your platform? What is it that motivates people the most? And if you told me today that if I ate more spinach, my hair would grow back, I would start eating spinach. I would. I hate spinach. But if I could do something to get my hair to grow back without taking a drug, I'd do it. I'm just saying, you have to find out what motivates people. Okay?
I totally agree. That's one of the biggest challenges that we see in the ED too, to talk, how do we get people potentially what we think is best for them, and how do we help them realize that it's best for them? It's sometimes you have to tease that out. What is it that they want out of this, and how would they change something that they're doing that's potentially harmful for them? And it's very difficult to figure that out when you only see them a couple times or once, in your lifetime. But I think that's what family could potentially tease out and help with, for sure.
Yeah, and I think basically, go if you're going, go make sure you go to the doctor's office with your loved one. Nowadays everything's done remotely, so it's easy. Just go hang out with them on Zoom. So be with the parent. Again, talk to their doctor if they'll let you. But again, I always found, but believe it. When I used to work in the VA, like I said, or any time a guy would come to the clinic, an older guy, I'd be like, and by himself, I'd be like, oh man, I'm not getting nothing from this guy. But when the wife would come, I was like, I'm going to get everything. And some people I would say, look, don't come back to my clinic without your wife. I'm serious. I would tell them that. And if you come without your wife, I'm not going to see you. So anyway, find out what motivates people and go to their doctor's appointments if you can. I'm sure most people do, but try to go to the doctor's appointments.
I think we're pretty much 7:02 now, so I think we'll wrap up. Thank you, both of you, Dr. Kraus and Dr. Mcmillan, for putting together this great presentation. We really do appreciate it, and answering all the questions. That was great. I learned a lot. I'm pretty sure attendees learned quite a bit.
It was my pleasure. Thanks so much for having me again.
Yeah, for sure.
I'm sure my mom, if she's looking down from heaven or looking up from hell, she's still smiling at her little boy. So anyway, you guys take care.
You too. Thank you.
Thank you. I'm still typing out answers. Are people going to be able to get these? Will these are these part of will these be posted?
What we can do is, if you are typing in answers, if you want to, are you able to copy paste it, or I can stay on and wait for those answers to be done, and we can email them out.
I'm going to finish the sentence and close it up, so then you can do it.
We can keep the session open a little longer.
Yeah. Yeah, totally. And then thank you all the attendees for joining us again this week. Next week, we're going to have internal medicine experts. We're going to have Dr. Richard Keel, who is a cardiologist, and he specializes in heart failure. And he's going to be talking about that, especially with meth use in the Valley. And then Dr. Roitman, who is our hepatologist. So she's a liver specialist. And she will be giving a talk about liver failures and liver diseases in the Valley that she sees commonly. Sort of goes with the Liver Expo that's happening sometime soon. But yeah.
You all will be in for a treat next week. Those are two of the high caliber people at UCSF. So you guys are in for a treat.
Thank you, Doctor.
It's a great week, but this is a great week. Thank you so much, Dr. Mcmillan, Dr. Kraus. I really enjoyed both of your talks.
Good. Thank you.
I'm so happy you were here. Dr. Kraus, thanks for taking a chance on us and doing Med. We appreciate it. I hope it wasn't too scary.
My goal is to be as fluent, as graceful as Dr. Mcmillan is.
I love it.
That's a low bar, Dr. Kraus.
Take care, everyone.
And Dr. Campbell, if we could all be as graceful as Dr. Campbell.
Take care.
Good night, everybody.
Thanks,
Bye-bye.
everyone. We will see you next week. Thank you so much.
Bye-bye.
Have a good evening. Bye-bye.